Hello, everybody, and welcome to a podcast. And FYI, folks, this is going to be on YouTube as well if you want to see what we're talking about. But this interview is one that I've been looking forward to for so long now. It's with Anna Crowle, a physiotherapist in the United Kingdom. I'm so excited to have you.
I'm so excited to be here. Thank you so much for having me.
You are so welcome. And can you tell us briefly where exactly you are located in the UK before I go on a bit?
I'm in Leeds in West Yorkshire, which is the north of England.
Perfect. Thank you. Yeah, so I actually was introduced to Anna's work through a colleague and friend and someone who's been on my podcast before. That's Denise Conway of The Flower Empowered. And she turned me on to one of Anna's videos, which was all about prolapse and a new way to really look at prolapse and approach prolapse. And I want Anna to do the explaining about this, but I just want to share with you all that Anna's work has completely shifted the way I speak about prolapse, because I used to describe prolapse, as many other physical therapists do, as a drop. But I think there's some elements of that's still valid in that wording, and maybe I'll let you explain your thoughts on that. But I think it's a little bit more helpful for people to think of it as a shift, and Anna's going to explain more, because the thing is, when you say it's a drop in the pelvic organs, it really causes, first of all, there's some inaccuracy to that, and secondly, it causes a lot of people to want to tense up really strongly to hold everything in, because nobody wants their pelvic organs dropping out of their body. And so it causes your body to just sort of seize up and tension to really take over. And I see so many women with tension being their primary concern, even if they have issues that typically we would think of and associate with weakness, like bladder leakage and prolapse, things like that. And so that wording of drop is really potentially problematic. So Anna, with that being my long-winded intro to you and kind of what caught my attention when you first started talking about that, can you please share more about your practice and how you treat women and how you explain prolapse and what you've seen?
Yeah, for sure. Thank you so much for having me. So I am a women's health physio, and my background is in myofascial release, and now I'm a researcher as well. And the focus of my research is in applying some really recent myofascial science findings to our understanding of pelvic organ prolapse. I believe that prolapse is caused by tension within the pelvis, not weakness. And to explain why I think that, I need to explain something called biotensegrity. So biotensegrity is essentially the way that the body works and the way that we know the body functions and is structured. However, our knowledge about biotensegrity is really quite recent. It's an anatomical concept and an anatomical model that really has only been around since the 1980s. So it's very much, it's a work in progress, integrating that into medicine and therapy generally. Mm-hmm. So I'm just going to explain what biotensegrity is and what it means, and then why that matters for how we see prolapse. So prior to the 1980s, way off into history before that, we have been taught that the body is built kind of like a stack of bricks. So the head rests on top of the shoulders, which rests on top of the spine, which rests on top of the pelvis, which rests on top of the legs, which rests on top of the feet, with the soft tissues draped over that. And that was how we understood human movement, and movement was taught to come from levers, okay? And then, actually we knew that there were some major problems with that model, but it wasn't until Dr. Stephen Levin in the 80s put forward a different model that our understanding in anatomy was opened up. So what he explained was that actually our connective tissue, which is also called our fascia, forms this stretchy dynamic web through every single part of the body. And basically that's the main supporting structure, and everything else is embedded within that. So the organs are embedded within that web, the bones are embedded within that web. down to the blood vessels and the nerves. So what that meant was that instead of us being a sort of top-down structure similar in makeup to a tower or a house, we're this self-suspending, stretchy, dynamic web that everything else is embedded within. And that just answered all these questions like, well, okay, how do we do a handstand and not fall apart? How do we function in crawling? How do we function swimming? How do we jump without these, big compressive forces coming through the body? How can we land gracefully and move so fluidly, like graceful dancing, that just doesn't fit with the old model? So the new model, Biotensegrity, it's answered many questions that we had in anatomy, and it's really been proven now through everything, cell biology, force mechanical calculation, everything. So the way that changes what we understand about prolapse, really, if we look at prolapse through the older model, okay, so the body is pieces in a puzzle all stacked on top of each other. The bladder, uterus or rectum falls down, and then we have to work hard to put that back up, okay? And many women who've had prolapse or experienced prolapse can say that can be a really frustrating process. It doesn't always give lasting relief to be trying to prop things up from below. So what we know from Biotensegrity is that movement really comes through the elastic expansion and contraction, okay? So it's all about stretch and recoil. And the pelvic floor is a very stretchy and dynamic area. We really need lots of stretch in order to urinate, to defecate, to, of course, birth, let alone move. Like squatting and walking requires, a stretching and an opening and a softening of the pelvic floor. So what we know is that the pelvic floor has to follow the laws of Biotensegrity. And the most important law of Biotensegrity is that things don't fall.
Okay, so it's definitely actually not even in your realm to be considering this as a drop or a fall at all, as far as prolapse is concerned. Mm-hmm. Okay.
Yeah, I mean, it's when we understand Biotensegrity, which is it's a modern and a new anatomical concept. It's the truth and it's proven, but we just haven't integrated that into medicine generally yet.
Yeah.
Fully. It's a work in progress, Mm-hmm. So within a Biotensegrity structure, such as humans, things cannot fall. But actually, deep down, we already knew that, because we know that our eyes don't fall into our cheeks if our cheeks are weak. We would never say his brain slipped down his neck because his shoulders. We would never say that, But still, within gynecology, there's this model based on the possibility that the uterus, the rectum, and the bladder can fall into the vaginal space. But actually, in a Biotensegrity structure, things don't fall. Obviously, things can go wrong in the human body and in the pelvic floor. And they go wrong by things being pulled out of their perfect alignment into a place with reduced comfort and reduced function. So what happens within the pelvic floor is that tension can build up in areas of the pelvic floor, which then cause more and more strain and more tugging and pulling onto the nearby soft structures. So in the pelvis, that's the bladder, the uterus, and the rectum. So where there is excessive tension in part of the pelvic floor, that will pull and pull and pull and pull onto the nearby soft structures until they're just not in the right place. They are a little low and a little to the left or the right. And that, of course, is a prolapse and is symptomatic of a prolapse. For example, if the tension is near the rectum, then what happens is that tension kind of sticks and adheses onto part of the rectum and kind of changes the rectum's shape a little bit. So it forms this pocket, which is what women with a rectocele will experience, is that pocketing of stool. Or, that tension might be more affecting the uterus and really dragging the uterus down into one side of the pelvis, which is, of course, the feeling that women have, is of that dragging. And the heaviness feeling is actually the tension itself. It's the tension in the soft tissues gives that heaviness. So really, I believe, based on, you know, the science of biotensegrity, and then I've applied that directly to my work with women, and so, you know, and my research is saying, look, these laws apply to this condition, and really my work is around finding and releasing tension within the pelvis, which allows the body to correct and reorganize, just as if we had a tight shoulder, and over time that eventually gave us a headache because it kind of pulls and tugs, and you'd eventually have neck pain and a headache. But then you can find the trigger points in your shoulder, release the tension in your shoulder, and actually your shoulder feels better, your arm is softer, your head feels better. And it's just the same in the pelvis. We can find the tension, release the tension, and allow that organ position to improve and be back somewhere where it's more comfortable and more functional.
Okay, it's perfect. This is so good. And this is, like I mentioned at the beginning, and like you mentioned, this really is groundbreaking. This is not the way it's typically described, even in modern training. And so this is incredible. So again, my new terminology that I'm moving toward about prolapse being a pelvic shift is something you would certainly say is acceptable and a good way to think of it. Okay. Yeah. And I love that, because my question had been is, you know, as much as we can use this new terminology, there is, in fact, the shift can be downward in some cases. So you're not saying that things will never move downward. You're just saying that this shift is causing things to be displaced, which it might be displaced in a downward position or a different position.
Yeah.
Therefore,
it's a pull rather than a fall. So the issue is that the injury, the cause of the problem, is causing the tension, which is a pull. So that is going to pull on the nearby soft stuff towards it. Now, if that injury is an episiotomy scar, it's going to pull the rectum or the bladder or the uterus towards that. So that is down, you know, that is further south towards the floor, you know, but it didn't fall out, but it's being pulled in the direction of the area of the greatest tension. Which for a lot of women, not everybody, but for a lot of women, that is related to scarring. So we have a lot of women who give birth vaginally will have some degree of pelvic floor scarring, either from an episiotomy or from a tear. And then what we know about scarring is that it tightens up tissue. So what we have is this nicely balanced pelvis, and then we have an injury in there which tightens up that bit of pelvic floor. It causes a strain and a pull through the system, which over time pulls more and more. And this is what prolapse-related pain is. This is that pain and that aching that a lot of women will feel. And this is why prolapses can kind of wax and wane. Some days they feel better than other days, or at different times of day. And this is because the level of tension within that tissue could be a little more or a little less, depending on what you've done that day.
Yeah. And also working, I'm sure, with the menstrual cycle and normal shifts and changes with the rhythms. Okay, this is fantastic. So my question for you, and what I'd love to cover today, is kind of how you assess the women that you work with and what things you look for. So obviously episiotomy and scar tissue, maybe a little more about that, and then where you go from there when working with them.
So again, kind of stepping out of the pelvis and looking more globally.
Sure.
So things that would normally indicate tension include pain, restricted movement, so stiffness of the area globally, and reduced tissue glide, so an actual stiffness to the tissue. So where someone has pain or reduced movement or stiffness in the tissue itself, we would really be looking for tension, you know, and that's a global, that's if you look anywhere on the body. So really I'm just applying those principles. So I would, of course, talk to women, talk through their birth story in quite a lot of detail, ask if there's been any other injuries to the pelvis or any other reason why there might be excessive tension in the pelvis, like a postural or a movement or an alignment issue is going to lead to some kind of tension buildup. So I would talk all of that through. And then I would have a look at them moving around. So without taking anything off, they would move around my room, and I can, as all physios, we get a trained eye in spotting areas that are not moving well. Yeah. So I would be saying, well, that hip's a bit stiff, and why does the hip not rotate here very well? Or why does that squat feel so stiff and tugging through your back? And so looking for feelings of stiffness and a reduced movement through the hips and the lumbar spine and the pelvis. And then I would move on to doing an internal assessment, which involves a couple of things. So one, I would ask everyone to take a breath in and a breath out, and on that out breath, close the pelvic floor, okay? Because the pelvic floor is supposed to have a natural oscillation on the in-breath. So when that's present, we can feel that. And when that's reduced, that takes some sensitivity of touch and training, but basically, when there's a good normal amount of tension and relaxation and softness of the tissue, then there is a natural oscillation on the breath. Now, when women can't contract their pelvic floor, I always ask why. You see, if we only measure, can this lady contract her pelvic floor, then historically the assumption has been, well, she must be weak. She can't contract there, so she must be weak. But, we've got increasing knowledge that says, well, maybe she can't contract because that tissue is stiff and stuck. You know, naturally, if we've looked already and said her right hip is really stiff, and hang on a minute, it's the right side of her pelvic floor that can't contract. And, she has an episiotomy scar through that right side. Really telling her that that's a weak pelvic floor is really unfair, because it is a stiff and stuck pelvic floor. And that's why she cannot contract that well, is because it's too stiff and too stuck. So that's the sort of thing I would be looking for. And then working to release tension where I find it, really.
And what are the methods that you use for tension release? Because I know your training and expertise is in myofascial release. Is it mainly that? Do you use movement as well, or?
I tend to focus on doing the myofascial release directly for women's scars or other pelvic floor tension. And then I refer locally to fantastic colleagues who teach self-massage to the abdomen, C-section massage, fantastic release-focused movement. And a lot of your work, a lot of your stuff is around release and softening and, anything from mindfulness and stretching. So anything at all which works to soften and release the pelvis. And it's different things for different women. For some women, actually, we need to tap into their anxiety because they feel like they're falling out. So the response to I'm falling out of myself is to grip and hold, and actually sometimes explaining to those women, you're not falling out of yourself, but that hip pain you have, that's kind of pulling you onto your bladder. So let's see what we can do for that hip and release that hip either through manual or movement therapy. And so it's different things for different women. In my clinic, I tend to focus on the myofascial release to the pelvic floor, and then I refer on to a fantastic network of colleagues so we can really work together, because the answer is not in one treatment. It's not like this treatment that I can do for your pelvic floor is the answer. The answer is us reframing collectively for women as a whole that this condition is rooted in tension, not weakness. So really we can treat prolapse in the same way that we treat pelvic pain. So we can take a multifaceted approach, different things for different women, but basically it's the same root cause.
Oh, I love this. I feel like all of the puzzle pieces for me and my practice in working with people in this online space in the way I do has really been gathering these puzzle pieces, and you just explain it so beautifully. I've been saying lately that kind of the global treatment that's basically appropriate for everybody, even though I tend never to say, there's no one size fits all. I really try to avoid that, but it does seem like almost anybody can benefit from releasing first.
Absolutely.
And it just makes sense that if you're tensing and you do have a shift in your pelvic organs, tensing around it is just going to perpetuate that shift. Yeah, exactly. So you must learn how to release first and work on that tension before anything can come back into its normal position.
Absolutely. The body is so intelligent, and where we release tissue stiffness or restriction, the body will reorganize. You know, the body it has its genetic intrinsic knowledge of where it's supposed to be.
Yeah.
So that becomes disrupted through injury, and the method that disruption happens is by that injury tightening and tensing those areas. And I think prolapse we've understood differently, really because of our understanding of anatomy. Our understanding of anatomy for hundreds of years has been that we are these stack of building blocks.
Mm-hmm.
And, you know, and actually, again, outside of the pelvis, but for the whole body, when biotensegrity has come along across the board, across medicine, people are like, oh, this is the actual truth. Oh, this is the missing piece in the puzzle. Oh, this so much better explains what's really going on. And that's all that's happening here with prolapse. It's an evolution. It's just we know more about the mechanics of the body. So we know that the pelvic floor follows those rules. So prolapse can't be a fall, but it can be a pull due to tissue tension or stiffness, just pulling things out of alignment, which obviously just revolutionizes what we can then do about it, you know?
Yeah, it sure does. And so what I wanted to do with you, if this is okay, is chat a little bit about maybe some success, a success story or two that you've had. I would love to hear a specific story or some of your research as well. I know you're doing research. And then I also would love to do a little more show and tell for the version of this interview that will be shown on YouTube. So does that sound okay for you, Anna, for the last few minutes of our time together?
Yeah. My most strong story is a bringing together of lots of stories, actually. Yeah. So, you know, I first started doing this work in 2015. And you know, at the beginning, I was like, "Oh, this seems to be working. Oh, this seems to be working very well." Oh, great. And then as I realised that this was something that I need to tell people about, I began to basically capture the data, like ask people for permission to collect data, and say, you know, I actually just need to take a snapshot of your symptoms now and afterwards, and then bring it all together and present that to the medical community, because that otherwise no one's going to listen, you know. Mm-hmm. So I did my first research paper that was published last year, and there's another one on the way which I'm hoping is going to get published in the next couple of months. And yeah, and so collectively there's about 50 patients, something like this. And for the ones that I've got statistical data about, basically what I've done is ask everyone to do this questionnaire at the beginning and at the end. And this is a questionnaire that is used by physios across the world to measure lots of treatments in lots of different ways. And I'm going to get really boring and statistical, but I find this really compelling. Yeah. So this questionnaire is set at 15%, 1.5 is the level at which they would say, okay, this is a meaningful treatment. Okay. Now, pelvic floor muscle training for prolapse, in all the trials that I've seen about this, is really skirting along in the kind of 5 to 10 to 12. So, you know, maybe better than nothing, but certainly not overwhelmingly helpful for everybody. Okay. And what I've got data-wise from the collection of patients that I've treated is something in the region of 50%, 50.
50. My gosh.
It just works so much better.
Amazing.
And so I'm not going to talk about individuals so much as I just want to give you that. It's a boring statistic, but I find
that's not a boring statistic. That's mind-blowing. That's amazing. And let's continue on with some visuals.
So I'm going to first show you my tensegrity model. Okay, so this is my tensegrity model that I've made out of coffee stirrers and elastic bands. So this is a good model of how we work globally. So the elastic bands are our connective tissue, also known as our fascia, and the coffee stirrers are the everything else, so the bones and the organs, okay? So for example, right, say this was your uterus, okay, and this was your pelvic floor, and you had a scar here in the pelvic floor. Can you see how that gets pulled towards it, yeah? Mm-hmm. So here's the pelvic floor, here's the uterus. I'm going to take a scar through that pelvic floor, say it's an episiotomy, and there you go, the uterus is pulled towards it. But then I can release that scar, okay? and then there it goes.
Oh, do that one more time. That was so good. I got to see that one more time. Mm-hmm.
So
Mm-hmm.
here's the uterus. Okay, and here are the sit bones, and here's the pelvic floor. And I'm going to take this section of pelvic floor and give it an episiotomy scar. And there's the uterus being pulled towards it. And then I'm going to release, and the body corrects. Okay.
Yeah.
And also, look at us doing a handstand. We do a handstand and we're fine. We can crawl. We can find, we're a stretchy, dynamic web. Okay. And this is how our movement works. So in the past, we were always told that movement was like a lever, but that doesn't explain how we can do this. Where's the levers in this? So now we know more that it's this expansion and contraction of space. Okay. And here is some tissue that would become scarred. So here is like a nice healthy piece of pelvic floor tissue. And then what happens when that takes a scar is this. So it gets all tight.
Yeah.
Okay. And then that pulls on the nearby structures.
So would you like to share with us a treatment technique that you use with clients and or that maybe people could even start doing on their own at home, knowing obviously that seeing somebody would be ideal, but...
Absolutely. So two things I want to say about this before I begin. So one, if you have a coil, you can still do this, but before you begin, you need to check the length of your coil strings. And then you need to check the length of your coil strings regularly. And if you notice a change in your coil strings, you need to go and see your nurse, okay? And unfortunately, this technique isn't safe to use if you've had major pelvic surgery. So if you've had a hysterectomy or an anterior or posterior repair, so that's a prolapse repair surgery, because what that does is that changes the normal arrangement. So this treatment that I'm about to show, this self-massage, wouldn't be safe for you to use on your own if you've got surgery or mesh in your history, okay? And also just seek out a local practitioner, okay? Just be under the care of a local women's health specialist, and also seek out the help of other practitioners that can help you soften and release your pelvis in other ways. So with breath, with movement, with meditation, with mindfulness, with work on your anxiety, with work on your feet and your hips and your buttocks. So be holistic. Seek out people that can help you release tension in the whole of your body and specifically release your pelvis. But I would like to show you what you can do if you think that scarring is part of what's happening for your prolapse, which for most women that would be associated with being able to feel the scar or a pain around the scar. Then I'm just going to show you 3 simple massage techniques that you can do. So I would recommend a couple of times a week, so for maybe 15 minutes, okay? So if this is you, all right, and this is your left side, and this is your right side, and I would recommend a kind of sat up in bed position. If you're sat up high on a chair, you can't really reach. And if you're laying in the bath, again, you've got difficulty reaching. But a nice sat up in bed, propped up, podcast, glass of wine, slice of cake, door is locked, kids are in bed, partner knows that he's not going to interrupt you. Give yourself some time and space. Because a lot of what you're doing is self-mapping. A lot of what you're doing is working out, where is my tension? Where is my stiffness? What is happening with my pelvic floor? And how does that relate to my prolapse?
Mm-hmm.
So once you've set the scene and you've given yourself some space, and so this is you, you've got your left and your right. Okay, so I would highly recommend using your right thumb when treating your left pelvic floor and your left thumb when treating your right pelvic floor, because otherwise it's really twisty, roundy and difficult to maintain.
Mm-hmm.
Okay?
Mm-hmm.
So I'm going to show 3 techniques. Now, not everyone gets on with all 3 of these techniques, and you don't have to do them all. It's mix and match. It's tools for your toolbox. Try them out, see which one works for you, and it might be different techniques at different times. So number 1 is the sweep. So primarily what we're talking about is the first rim of tissue, okay? Because this bit of tissue here, the range of motion, the direction that this tissue goes in is this, right? To crown our babies, right? So when our babies come down through our birth canal, what happens to this tissue is this. this.
Okay.
Okay. And so the area that does the biggest expanding and lengthening is just here and just here. So if this is a clock face, 12 o'clock and 6 o'clock, it's the 5 o'clock zone and the 7 o'clock zone, which undergo the greatest expansion. This is also the area where a lot of scars run through, which tightens and tethers up this area and then causes a pull through the pelvis. All right? So this and this is your target area.
Okay, so we've got our 5 o'clock and our 7 o'clock, and
okay,
that
5
area.
o'clock and 7 o'clock. Okay, so right thumb. Because we're working on this most superficial area of tissue, you only need to go about yay deep.
Okay.
Okay. So you're going to sink in at the 6 o'clock zone and then just sweep out. Okay, so from about 6 to 9. 6 to 9. And 6 to 3. 6 to 3. So you don't really want to go rub, because that's going to irritate things, but a nice outward sweep.
Okay.
And outward sweep. And at the beginning, while things might be really sensitive and sticky and stiff and sore, so you might only really be working at a really light pressure. But as things progress, you might feel like you're more able to really move the tissue, yeah? Okay. So for some women, they need to sit with that move for some weeks if things are quite sensitive or stuck or sticky, or it might feel sharp or scratchy or gristly, and actually just a nice outward sweeping motion. Okay.
And can I ask a question? Is this for any specific type of prolapse? Is this more useful? Have you found, like, for example, is this more likely with rectocele or with cystocele or with uterine prolapse or etc.?
So it's the same basic 3 massage techniques for wherever your prolapse is. So the difference in prolapse comes from the difference in location of the scar. So they almost always in those back corners, okay? But the way that scar pulls through the pelvis affects the type of prolapse that you get. So if the scar runs near the rectum, it really pulls on the rectum, and you can end up with the rectum kind of stuck next to the scar, okay? And then doing this work will gently tease that rectum away from the scar, okay? And for the bladder, it's more that there's this big kind of sweeping connective tissue structure, which if that gets pulled on, it becomes tighter, and then the bladder goes over here. So if we release here, the bladder will move back into a better position. So these 3 techniques I'm going to show you are suitable for any of those 3 types of prolapse. As I said, not if you've had an anterior or posterior repair or a hysterectomy. It just changes the anatomy. Okay, perfect. So if you've had that surgery, you need to seek some help. Okay, so we've got this nice sweeping maneuver. So out and out with a steady increase in pressure over the days and weeks that we practice it. Okay, and next is a bit more focused on this 5 o'clock and 7 o'clock zone. Okay. Right, so what I'd recommend is take your thumb and put it just inside, okay? And then take either 1 finger or 2 finger just onto the outside. So you're really grabbing hold of the rim of your vagina at the 5 o'clock and the 7 o'clock position. So some women just can't get any purchase on here, and that's fine. It's different shapes, okay? But for a lot of women, that might have you right over your episiotomy scar, okay? So just take hold of the tissue there and there. Okay, so when you're there, again, you can do what feels right. So you could do some squishes, okay? Or you could do some rubbing and rolling like this, all the way up to this. This is fantastic for really mobilizing this tissue. And bear in mind, this is the bit of tissue that when we birth our babies goes whoosh like this. It lengthens up to 3 times its resting length.
One more question. Have you noticed, for example, me, I did not have an episiotomy. I was blessed to avoid significant tearing, but have you seen that it's possible that even if you're not aware of, it's possible there's still some scarring, because obviously a lot was stretching and
So the scar is common, but it's not everybody. You know, it can just be tension within the pelvic floor. So that might feel like achy or like a knot or a bruise. The sensations that you would have if you were treating a knot in your shoulder, very similar.
Sure.
So when you're on scar tissue, it feels like scratchy, gristly, sometimes a bit sharp and sticky. And when you're on just some tight muscle, it can feel more like deep ache.
Achy.
But either way, this is going to respond the same way.
I was going to say either way, these techniques will be helpful. Okay, so we've gone through the sweep and we've gone through the essentially skin rolling, right?
So, and on, so one finger or two finger, and then a kind of this. But you're going to have to work yourself up to that. That's not going to happen today. These are just tools for the toolbox. You can really mix them up. Start really light, listen to your body. You don't want to cause yourself real pain or any bleeding, but just start gently and then just increase this in, do this regularly. So the third move I'm going to show you is more of a static kind of classic myofascial release kind of move. So where you feel that tension, okay, so say it's here, right, where you've gone over it and you've tried to squish it, but there's still this tender or scratchy part of the pelvic floor. So what you want to do, and you have to be really calm and really gentle, okay, is basically just plant your thumb right into it and then gently sink.
Okay.
And as you sink and hold that sink for say 30 to 45 seconds, you should start to see a bit more of a release. So what you want to avoid is like pushing and forcing the tissue, because the tissue is just going to bounce right back, but equally you don't just want to be kind of on the surface. You do want to plant your thumb into that sore area, that tender area, that scratchy or gristly area, and then nice deep breaths, nice and calm, and just sink. Very much like you would with a knot here on your shoulder. You wouldn't force it, but you would just, there's a certain pressure. It's a sink. It takes some time. You don't want to force things, but that can help move that release on. And then you might want to go back to the sweeps. Then the sweeps might feel more effective. So those three moves you can use to get going, but I would certainly add in mindfulness work, stretches, release-based movement therapy, massage therapy to the buttocks and the thighs and the belly. It's something to add into the mix.
This is so great. And I was just thinking as you were describing that it might be nice for people to actually do some release work using these basic techniques on their shoulders or on their neck muscles, just to kind of get a sense of how it does feel if they've never done their own self soft tissue work, just to kind of get a sense of how that does feel, to sort of sink into the tissues and let it melt a little bit.
Because a lot of it is in the feel. So that's why it's good to start really with just self-mapping, just going down there and finding your way around. Where is sore, where is tight, where is scratchy, and be aware that that's actually a really stretchy, dynamic bit of tissue. This what happens at the entrance to the vagina, to the point where the vulva and the perineum become the vagina, this is not this shape, it's this shape, which then becomes all folded up and becomes this shape. So it's actually, it's a lot of folded up tissue here, which really allows us to birth our babies and then function in every other way. And that back area here, the 5 and the 7, this is a fairly thick bit of tissue.
Yeah. This has been incredible, Anna. How can people just get in touch with you? How do you work with people from afar?
So since COVID, I've started doing online consultations, which has been great. And then I can look at people move, and, we can do certain movements to work out where in your pelvis your issue is coming from. And then, make sure that you're doing everything that you can access locally to you. Do you have a massage therapist on board that can help you with this and this? And then I can show you some more specific, there's more, that's your sort of basic move, but there's more that can be done that we can talk through, and I can show you as an online consultation. And if there's any professionals that are interested, on my website, I've got a little mini seminar. It's like an hour long, and it's just for professionals working with women. It just goes more in depth, really, what I've said, but more in depth.
Perfect. Anna, thank you so much for your time. This is just a taste of your knowledge and your information. And how can people be alerted about your upcoming research paper?
Oh, that's a good question. Well, I'll be posting it on Facebook. So if people want to like my business page, it's called Anna Crowle Physiotherapy, and they can like that page on Facebook, and then I'll be posting links to it on there. Usually with the research, the publishers say, look, for a while only this bit is available for public access, and then for a while this bit is available for public access. It's kind of up to the publishers what they choose to do with it. But I'll certainly be putting any links onto my Anna Crowle Physiotherapy Facebook page.
Perfect.
Thank you so much for having me. This has been so nice to meet you as well, and thank you for all of your work with women. You do so much for women, and so much of it you make free to access, and that's just wonderful. So
I thank you for that. It's my passion and my pleasure, and it's really a pleasure to meet people like you who are such pioneers in this. So thank you for your great work, and we'll see you next time.
Lovely to meet you.
Bye.
Have a nice day.